we should be able to talk about it within an hour or so. So in this class, I'm going to define what pigments are. I'm also going to classify for you pigments, give examples, and also tell you the disease processes that involve pigments. And for start, maybe I should ask a few questions. Who can tell me what pigments are? I'll choose randomly. I don't know you, but I have the participants here. Maybe I should start with you, Kelsey. What are pigments?
I think like colored compounds.
Oh, great. Do you know, can you classify some of these pigments, or do you know any classification?
Okay, I think acidophilic and basophilic.
You could classify them as such, but for purposes of this class, I rather look at them as either arising from outside the body, that is exogenous, and those that are produced within the body, that we call them endogenous. And then I'll ask randomly, Michelle, I can see a lady called Michelle Aroko. Are you there? Michelle?
Yes.
Good morning.
Good morning to you too.
Tell me, which pigment do you know? Any, give me randomly, any pigment.
Melanin.
Very good. Do you think it's an endogenous or exogenous?
Okay, I'm not sure about that.
Endogenous arise, they are within our body, and exogenous are those that come from outside our bodies.
Oh, endogenous.
Great. Then I'll also ask, let me look for a gentleman here, Raymond Atura, are you there?
Yes, I'm there.
Give me an example of another pigment.
Not maybe chlorophyll, the one that is in plants.
Yes, that's a good example, but we are in medicine, we are not in botany. So I'm looking for a pigment found in human beings.
In human beings, I'm not so sure.
I can trick you a bit. If you see somebody's eyes are yellowish, which condition do you think they're suffering from?
They have the jaundice.
Good. Jaundice is a condition where there's yellowish pigmentation. Which compound or which what is responsible for that yellowish tinge?
Bilirubin.
Very good. So bilirubin is one kind of a pigment that's within our body. At least now you are following me. Then there's another president here called Bill Clinton. Bill Clinton, are you there?
Yes, I'm around.
Since you're a president, you must be knowing one pigment. Give me an example of another pigment following the footsteps of those who have discussed a few pigments. Which one do you know?
Yeah, so for the pigments, I know there's this counterpart of bilirubin called, kind of forgetting it, but I can talk of others.
Yes.
So I don't know what to talk about. The one I had in mind, like melanin and bilirubin, is talked about. Carotenoid.
Yeah,
What about carotenoid?
Which one is this? Is it an exogenous or endogenous?
Endogenous.
What is it responsible for?
Not sure, though. I just saw it sometime back when I was reading I don't think it's around vitamins. Yeah.
Okay, maybe that's a new one. You don't have any other obvious one?
No.
Okay. Let me ask another one. A lot of you have had difficult names. Let me look for an easy one. Clarence Mwangi, are you there?
Hi, yes, I'm there.
You have seen individuals who have pigments on the skin, and these pigments, they inject them. What do you call this pigment? Do you have one?
The skin melanin? Is that?
No. These are injectable. They inject into their skin. I think it's fashionable.
Oh, tattoos, you mean?
Yes, tattoos.
Oh, okay.
Is tattoo an example of a pigment?
I'm not sure.
Yes, I'll tell you it's an example. Do you think it's an endogenous or exogenous?
It's exogenous.
Great. So these are the kind of things that we are going to be discussing about. And I think now you have what I'm talking about. We are talking about pigments that we see within our bodies. Some of them that come from outside, so we call them exogenous. And some of them are within our bodies. Some are normal and some can be seen during disease conditions. And that is the example of what we are going to deal with today. So without much ado, these pigments are colored substances. And these substances could be normal constituents of cells, as one of you said, melanin, whereas others are abnormal and accumulate in cells only under special circumstances. And we are going to look at some of the common pigments, the rare pigments. Some of you have mentioned, you can think about them. But today I'm going to look at the common pigments, both exogenous coming from outside our bodies or endogenous that are synthesized within the body itself. More commonly, we are going to look at the more endogenous because these are some that you're going to deal with commonly. The two common exogenous pigments that we see commonly is carbon or coal dust. And as we have mentioned in the last, that tattooing is some of, it's not a disease process, but we see it now commonly, people injecting these pigments. And we're going to see the only problem with these tattoos is it's a permanent picture. So if you wrote somebody's name on your skin and suddenly you are not in good terms, it may be difficult for you to remove that name. So let's look, and then of course there will be many endogenous, and we are going to look at them. Straight on, the most common exogenous pigment is carbon. Okay, you have been hearing about carbon, people sitting to talk about carbon and its effects in the environment, but we are not interested in global warming. Today we are looking at what does it do to our tissues. So carbon, also referred to as coal dust, is the most common exogenous pigment. And this carbon is what is released to the air from fumes, either fire, vehicles, industries. So the smoke, smog, and all these that you see in the environment, especially in urbanized areas. Recently, I was hearing about India, New Delhi. You cannot see somebody who is maybe 20 to 30 meters away because of excess smog. And this is because of the air pollution that is available. So this is the commonest air pollutant of urban life. And as you can see, how does it get to our bodies is mainly through inhalation, because this carbon pigment, together with other gases, they're within the air, And then we will inhale them, and they will enter into our macrophages, which are then lodged into our alveoli, and then they are taken into the lymphatic channels. From the lymphatic channels, they are also transported to the regional nodes in the tracheobronchial region. And I've been saying that this is the commonest because of air pollution. And as you can see, if I may go just as we are going around doing dissection, you'll note that our lungs are not this glistening grayish. There's some dark particles within the septa, and this is carbon pigment. When it's excess, and especially those of you who are smokers, then this dark pigment will be lodged within the alveoli and the regional nodes. And these are the alveolar macrophages that ingest this dark black pigment, and the condition is referred to as anthracosis. So what's anthracosis? Anthracosis is accumulation of carbon pigment that results in blackening of tissues within the lungs and the involved regional nodes. So this storage of carbon particles in the lung and regional lymph nodes, most of the time ill health, but is referred to as anthracosis. In excess, especially in people who work in very dusty conditions, in coal mines, remember coal is mined deep in the ducts, and it involves creating a lot of aerosol, and these carbon pigment are inhaled, and with time, they cause emphysema, which is a fibroblastic reaction of lungs, or a lung disease referred to as coal workers pneumoconiosis. Literally, the whole lung becomes black. So you can imagine that coal is like charcoal. So if you are crushing charcoal, all those fumes, then somebody inhales them, especially in places where people are not wearing masks, or even if you are wearing masks, the excess dust will be inhaled in the lungs, causing this condition. It's one of these work-related occupational diseases, and hence it is referred to as coal workers pneumoconiosis. So in small amounts, you can see here, this is the lung, and then there's this dark in the septum, and this is referred to as anthracosis, and it's caused by inhalation, ingestion of carbon pigment by alveolar macrophages that get settled within the alveoli and interstitial spaces. And you can see here also a lymph node. In the regional lymph nodes of the lungs, the highland nodes also ingest more of this carbon pigment. And hence, if you're dissecting the lung, you will see this dark black pigment within the alveolar sacs and also the regional nodes, and you know this is carbon pigment. And as we have seen, in excess, it can cause serious lung disease. It starts with emphysema, and it continues to what is referred to as coal workers pneumoconiosis. And in excess, this causes lung chronic obstructive airway disease. You may ask questions as we go along. You may ask through the class rep, or you may unmute and excuse yourself and ask the questions so that I can readily answer. The other exogenous pigment is tattoos. So as you know, tattoos, it's like a fashion nowadays. It's caused by somebody injecting locally to the skin exogenous pigment, which is usually insoluble, metallic, and sometimes vegetable pigment. So you choose the pigment, you want a colored pigment, you want bluish, you want black, and then this is injected, okay, into the skin. Low if it goes into blood, because then you may have a serious reaction to this kind of pigment. The introduction of this soluble metallic into the skin is by somebody's own choice. But then what happens is that this pigment is engulfed by the dermal macrophages. But because the amount of injected pigment is in excess, then they form these, depending on what somebody wants to write on their skin, maybe they want to draw a dragon showing they are a tough person, or they're memorizing a certain route, like thieves who want to put them on the skin, or all these things that people are putting, crosses, butterflies, and so on, snakes. Remember that these persist for a lifetime. But because of the engulfed pigment by these dermomacrophages, initially it may fade a little bit, but then you may inject more so that it becomes more permanent. As we said, it persists for a lifetime. And the only problem is if you want to remove this tattoo for one reason or another. Those two are the exogenous pigments that we were to discuss about. There are not that many exogenous. The other ones that we usually see are heavy metals. So you can read about heavy metals like sand, that people work in sand mines, in quarries, where they're blasting all these or cutting into stones. Sand ideally is not pigmented. It looks colorless most of the time, but when it accumulates within the lungs and other places, it takes the color of which metallic substance which is being ingested. But that we leave it for you to go and read about heavy metals that are pigmented. For example, beryllium, leading to a condition referred to as berylliosis. When you have heavy metals that are being ingested or being inhaled, especially in people working in those kind of situations. Let's now go direct and look at some of the endogenous pigments. I'll pause a bit to hear if there are any questions.
One question from the chat is, does excessive tattooing cause cancer?
Not that is known about, that excessive tattooing may not cause cancer, but it may cause irritation of the skin. So you may find contact dermatitis. People have their skin peeling off, especially if they are reacting to some of these tattoo pigments.
Oh, thank you. Another question is it true that you can't donate blood after tattooing? And if so, why?
I beg your pardon?
Is it true that you cannot donate blood after getting a tattoo? And if so, why?
The reasoning behind, remember that the injection of tattoos involves use of needles. While use of needles has its own hazards, like spread of hepatitis, hepatitis B, hepatitis C, and also spreading of diseases, especially if these needles are not thoroughly sterilized. Also, remember that people who put tattoos are thought to be people who are involved in risky behaviors. And hence, if I'm the head of a blood donor program, I'll have to be very careful to screen these people who have tattoos because of the risky behaviors that they have been involved in, because the needles that are in use could be shared by many people. Because remember that some of these tattoos people put are to identify themselves with certain groups. So because of that risky behavior and risk of spread of diseases like hepatitis, then when I'm choosing somebody who is donating blood, then I'll be very, very careful with somebody who has tattoos. But the pigment itself has no effect on blood. The only issue is if it enters into blood, somebody can have an anaphylactic reaction. Remember that most of these tattoo pigment is subcutaneous. So principally it's not entering into blood, but if you inject that pigment in blood, you may be having serious problems. You may have an anaphylactic reaction. So from there, it's because of the risk of spread of diseases, just like the injections that an IV drug user uses. So if an IV drug user comes to donate blood, have to be very scared because of the risk they have involved themselves in especially rare diseases, rare viruses that can be transmitted from one person to another.
Okay, thank you. The last question I can see is, why do tattoos fade over time?
Well, it's just the thing I've said that once you inject, the body reacts, the dermomacrophages just beneath the skin, they are macrophages, Langerhans cells. So the initial injection, these Langerhans cells accumulate in that area and try to ingest these pigments. So if you see, that tattoo may become lighter because of that ingestion by the Langerhans cells or the dermomacrophages. But to make so that you swamp them, you add more tattoo. And hence you will find that somebody whose tattoo becomes pale may go and add more pigment so that it becomes permanent.
Okay, thank you. That was the last question.
Okay, so then let's proceed on. Now let's look at the more important pigments, which are the endogenous pigments. These endogenous pigments, as we said, they are pigments that are produced within our bodies. The first one here is referred to as lipofuscin. Lipofuscin, also referred to as lipochrome, is a wear and tear pigment. It comes because of wear and tear of cells or tissues as they age. This lipofuscin, as you can see, is a mixture of lipo, which is lipid, and fucin, which is a protein. They are golden brown in color, and they are sometimes, this lipofuscin sometimes is referred to as, the chemical in it is referred to as steroid. So lipofuscin by itself, it's not injurious to the cell or its function, but it's a marker that this cell has undergone aging, and hence this material which has accumulated within is because of tear and wear. So it's a telltale sign of free radical injury and lipid peroxidation, which are biochemical processes that go on as the cell continues with its own functions. It's yellowish brown or golden brown. Is found within the cytoplasm, especially in the perinuclear region. Remember that the cell has a nucleus and a cytoplasm. So where do you find? There are some pigments you find within the nucleus. There are some pigments you find within the cytoplasm. These pigments is found within the cytoplasm. And as it's said, it is seen in cells that are undergoing, they have undergone aging, or they are dying because of age. So it's seen in cells undergoing slow regressive changes, and is particularly prominent in the liver and heart of aging patients. It's also seen in patients with severe malnutrition, and also in dying cells within our bodies due to cancer or cancer cachexia. That's why it's sometimes referred to as brown atrophy of the heart, seen in the liver and heart of aging patients. These are the cardiac myocytes, and you can see the intercalated cells right there. And you can see here, this is the nucleus, the blue stainings, the parts are the nucleus of the cells. And then round about the nucleus, you can see these finely brown pigment, and this is the so-called lipofuscin. On the electron microscopy, you can see this is the nucleus of the cell. And the perinuclear region has this very dark black pigment, and this is what we call lipofuscin. Here, these are hepatocytes, and you can see them with these sinusoids and these very large cells with granular. And you can see here, these are red cells, and of course, you know the red cells are red. And what I'm interested in is this is the cell, and this is the cytoplasm of the cell. And you can see here this finely golden brown granular pigment, and this is lipofuscin. So this lipofuscin, seen more here as a finely granular golden brown cytoplasmic pigment, is the so-called wear and tear pigment, and we have seen it is seen in aging cells or tissues, especially in patients who have severe malnutrition, so the cells are dying, or patients on treatment for cancer, and hence some of those cells are dying and leaving this pigment, or very old patients who are aging, and we see them in the heart or in the liver. So this pigment is an endogenous pigment, is a telltale sign of free radical injury and lipid peroxidation, and it's referred to as lipofuscin. Okay, let's go to another pigment referred to as melanin. It comes from the Greek word melas and is responsible for the black pigment that you see in our skins. All races have this pigment. The degree of pigmentation is what differs from the so-called brown, from the so-called white or races. They still have pigment, not too high, to the dark-skinned pigment that you see in our skins. So melanin is an insoluble round to black pigment found principally in the epidermal cells, also called keratinocytes, of the skin. It can also be seen on the eye. So the retina has also this black pigment, also referred to as melanin. This black pigment sometimes is seen in other organs extrinsically or ectopically because it's not supposed to be there. So don't worry or don't wonder if you see black brain or black intestines, because sometimes some people have this pigmentation in other organs, but principally we see it on the skin and the eye. And you know that melanin is protective against UV radiation, and we are going to see these conditions whereby we have people who are hypopigmented, and this hypopigmentation causes lots of problems to lack of pigmentation causes lots of problems to these hypopigmented conditions. So as you know, it's a non-endogenous. It's not derived from hemoglobin. We are going to see pigment derived from hemoglobin. So how do we form melanin pigment? During the process of oxidation of tyrosine to dihydroxyphenylalanine within our melanocytes, and you know melanocytes are on the basal layer of the skin, we see that condition results to the formation of this so-called pigmented dihydroxyphenylalanine. And that's why the skin now is pigmented, and the degree of pigmentation is what varies from the very dark pigment. Even within Africans, we see that there are certain races or certain tribes, especially from Sudan, who are very dark. Even from the early ages, it was noted. To others who are a little lighter or even yellowish, people call them yellow, but they're a bit lighter. To the very lightly pigmented races like the Caucasian groups. And remember that this is a reason that there is racism, just because of the pigmentation of your skin. Otherwise, we are all the same. We are going to see that locally, we can see certain tumors that are pigmented. And we can also see that our skins can just increase the pigmentation, especially when you are sun exposed, especially those of you who have gone for holidays. But more so, we have seen certain conditions like Addison's disease, which can give you a telltale sign that somebody could be having a problem. Other than that, the other issues are really social issues. Like we are going to see in this picture here, this is skin, and we know that there are how many layers of the skin? Maybe I may not ask you, but it's in the basal layer that we see melanin being produced by melanocytes. A few times, this melanin can be in excess, okay? That you see these dark spots in people that we call nevi, which are benign accumulations of melanin pigment, nevi. Some of them may become malignant in condition referred to as malignant melanomas. Melanoma from melanin accumulation. So a few neoplasms, we are going to look at them later on when you come to third year and fourth year. Beauty spots, people call them beauty spots. They are not beauty, they are neoplasms. So you find if they're benign, we call them nevi. But if they become cancerous, we call them melanomas. So those are tumors that have melanin. And you can see the arrows pointing to this brown-black pigment within. This is the skin. You can see the epidermis there, and this is the dermis. So there is melanin within the dermis, and we call this nevi. Sometimes some of this melanin may extend into the epidermis. You can find melanin within the epidermis and the dermis. We call them junctional nevi. So you can have epidermal nevi, intradermal nevi, or junctional nevi. When they start growing them, and sometimes they can be irritating, especially men, if they are on your chin or somewhere where you need to keep shaving, so they are irritant, and you keep shaving them, you may transform them, and they can get irritated and become cancerous. Some ladies sometimes leave them on certain areas of the face as a special marker, but be careful, if they keep growing, they may become cancerous. And this is an example of how melanocytes look, and you note them because of this brown-black pigment. Now, more commonly are people or conditions, congenital disorders where people have hypopigmentation. And you have seen them in our communities. Global hypopigmentation, from the hair, the skin, the nails, even the retina becomes pale. And this congenital disorder is referred to as albinism. And some of us, we have relatives or even our own siblings who are hypopigmented. This condition, most of the time, is due to a lack of melanin due to a deficiency of the enzyme tyrosinase or tyrosine oxidase. And remember that the conversion of tyrosine to dihydroxyphenylalanine by tyrosine oxidase results to the melanin production. Ordinarily, most of these people should only suffer because of excess UV light. And this excessive UV light is irritant. It irritates the skin, leading to skin cancers. It also irritates the eye because of the excess UV light that goes to the retina and causes somebody not to see properly. And you see a lot of the people who have hypopigmentation having these, they keep twitching their eyes because of the effect of direct UV light. Other than this, socially, we have seen people who have hypopigmentation, the albinos, being targets of witches and other superstitious people who believe that their tissues, if they eat their tissues, they will be cured of HIV, impotence, and others. We have seen this, especially if we read the media in our neighboring country, Tanzania. A lot of, we see a lot of magicians and witchcraft, people who are targeting them, they kill them. And people who go them for treatment of diseases, then they are given some of their tissues thinking that they'll be cured. But this, of course, is not true. And the main problem we have seen in hypopigmentation, global hypopigmentation in albinism, is they're susceptible to skin diseases, basal cell carcinomas, squamous cell carcinomas of the skin, and even some of them, you will see the skin which is crusting out because of direct UV light. This condition of hypopigmentation is congenital, meaning they're born with it, and is referred to as albinism. This is an example of somebody with, we call it hypopigmented disorder. But you can see hair is pale, the skin all around is pale, the eyebrows are pale, and most of the whole skin is pale. They get this excessive irritation of the skin, especially around the lips, the nostrils, the eye, the eyelids, and other sun-exposed areas. And that's why I'm saying they get these skin conditions. And more so, they are susceptible to skin cancers. And that's why they're advised to wear capes, to wear sunscreen, to wear goggles, and to wear long clothes. And this is to protect them against UV light. Any question on albinism? Kelsey?
In the chat, I can't see any on albinism.
The other condition which is acquired is referred to as vitiligo. Unlike albinism, this is acquired. And it's an autoimmune condition. Just a minute. It's an acquired and is an autoimmune condition, meaning that there's autoimmunity against melanocytes. Our body reacts and destroys our own melanocytes, leading to hypopigmentation. But as we are going to see, this hypopigmentation is not global. It's not the whole body like albinism. It's in certain areas. Which are the commonly affected areas? The commonly affected, so it's patchy loss. The commonly affected areas are around the mouth, so perioral, around the anal region, so perianal, around orifices like the ears. So you have seen these people around the digits, around the lips. So sometimes depends on which areas are affected, around genitalia, okay? So you find certain areas for whatever reason, which is unknown, start losing pigment, okay? And you have seen people who are like this around the eye, so around the eyeball, around the eyeball, around the mouth, around the anal region, around the eye, the ears, they start losing pigment around the lips. In fact, there's some condition referred to as lip tip vitiligo. So you find somebody losing pigment around the lips because of excessive sun exposure is also one of the risk factors. So the rate of melanin loss and the extent is unpredictable. So you find that somebody with just mild and others with excess or widespread loss. And the rate of loss, melanin loss, is unpredictable. This is one that's called, you know about Michael Jackson and his skin transplants because of vitiligo. He started noticing that the tip of the nose, the lips, and around the eyes, there was loss of melanin. And it was the reason why he was working with that umbrella everywhere. It's because of the fear that melanin loss was going to be widespread, causing him aesthetically to look bad. But he also decided to have transplants. Some work, some don't. You may find also those transplants also because of the innate autoimmunity starting to lose pigments. So that is what's referred to as vitiligo, a condition in which there is melanin loss and it's acquired, is autoimmune. So somebody starts with normal skin pigmentation, but with time, they start losing melanin in this condition referred to as vitiligo. I'll pause again to see if you have any questions.
Yes, one student is asking, what triggers the body to target its own melanocytes?
Some of it is genetic, some of it is environmental. The genetic trigger is not clear, but you find in certain people, in certain families, there's increased autoimmunity. So you find autoimmune diseases. So if it's to the pancreas, they form diabetes mellitus. If it is to the thyroid, you start finding thyroid disorders. So those autoimmunity, so they can also target the melanocytes. So that is genetic the trigger of which is not known. But if it is to conditions like vitiligo, some of the triggers are excess UV, so skin irritation. So that you find a lot of sun-exposed areas having the hypopigmentation. But hidden areas like perianal areas, the trigger is unclear. And actually, most triggers for autoimmune conditions are not known.
Oh, thank you. Another student is asking, is there any way of stopping the condition from progressing if you have vitiligo?
Yeah, so to reduce, depending on the risk factors, for example, lip tip vitiligo around the lips, is to apply. There are a lot of drugs that protect that area against excess UV radiation. So you get sunscreen. There are drugs like tacrolimus, those ones you learn them in dermatology that prevent. But despite that, there are people who still progress rapidly because, as we have said, the extent and the rate of sometimes unpredictable. But if you know, especially if you're working in outdoor areas and you have developing these vitiligo, probably changing your workplace may lead to decreased progression of that condition.
Okay, thank you.
Another condition that you may learn during biochemistry is referred to as ochronosis. This is a metabolic disease. It comes around because of accumulation of one compound referred to as homogentic acid. This homogentic acid is black, and the condition is referred to as alkaptonuria. And alkaptonuria is a condition whereby when somebody urinates, then they urinate black urine. Okay, you may not see this because sometimes this urine on sun exposure turns on black. Maybe if somebody is out there urinating in the open, is maybe you can say this person has alkaptonuria, but rarely will you be able to see this. So this condition is referred to as ochronosis, or when they urinate black urine is referred to as alkaptonuria. It's a rare metabolic disease. This homogentic acid can be deposited in the skin, connective tissue, and cartilage, and because of it is pigmentation, black pigment, then it will be referred to as ochronosis. So take note during your biochemistry when you are learning these metabolic processes, and the homogentic acid will come into form, and you'll find out that because it's black, then it leads to either alkaptonuria, urinating black urine, or tissues become black, referred to as ochronosis. So compound is referred to as homogentic acid. In the same, I may not come to it, that those, one mentioned it, whereby somebody, that there's this fad of eating excessive carrots. So that carrots, in terms of juice and so forth, carotenoids, you may get excessive accumulation of that, I don't know if it's yellowish, the pigment with carrots. So you find that people have skin that has changed. So carotenoids, as somebody had mentioned it, is because of excess ingestion of carrot juice or carotenoids, which is a compound. It doesn't cause disease, but it may change your skin pigmentation, or even your retina changes color. And people take it because they think it's healthy, but not always that to be healthy. It may change your skin complexion. Okay, so let me go to another condition referred to as hemosiderin or hemosiderosis. Hemosiderin is a yellowish, golden yellow to brown pigment that comes as a result of hemoglobin breakdown. And hemosiderin is one of the major storage forms of iron, and you're going to learn it also during your biochemistry classes. So you note that on breakdown of hemoglobin, the heme part, which has iron, then when it's broken, iron has to be carried off and be stored. From the breakdown sites, this iron is transported in blood with proteins referred to as transferrin. Just a minute. Sorry about that. So iron is not free floating within blood. It has to be transported in with the so-called transferrins. Once then it's transported by transferrins, then it has to be stored. So it can be stored, and the main iron stores, as you know, are within the liver and bone marrow, and also in the spleen. So in those cells, it is stored and associated with a protein referred to as apoferritin. So when apoferritin in huge amounts lumps together, they form what is referred to as ferritin micelles. When these become in excess, then they have to be stored in a form referred to as hemosiderin. So when there's a local or systemic excess of iron, then the ferritin forms what is referred to as hemosiderin granules. This can be visualized with a light microscope. So this is the iron metabolism. You know about it: iron in diet, intestinal epithelium, transported with transferrin all the way to the liver, spleen, and bone marrow. And in excess now, this now becomes when we get excess, especially when you have hemoglobinopathies. So hemoglobin problems where hemoglobin is continuously being destroyed. You can also find in conditions whereby, like in local conditions, like where there is a trauma. Let's say you have been hit on the eye and you form some hemorrhage, like a bruise. So breakdown of those red cells, there will be storage of iron in that area. And this is what is responsible of transformation of what was looking like a reddish or bluish hematoma to eventually a golden yellow because of iron, which is in excess in that area. So this is what we are talking about. That especially if you have a black eye, you have been punched in a brow, initially it looks red or bluish, but with time it changes its color. Especially light people, you'll see it turns into yellowish color, and that yellowish color is because of hemosiderin. So that's local excess. But we are talking about some conditions where there's systemic overload. And this you'll find excess iron being stored in many organs in the liver, the bone marrow, and this condition is referred to as hemosiderosis. And hemosiderosis can arise whereby there is increased absorption of dietary iron. So there are people who have this excessive intake of iron, the pregnant mothers, they're eating rocks made of iron, and then they start developing excess iron in a condition referred to as hemosiderosis. There are people who have what is called hemolytic anemias. You learn this when you come to hematology. They have hemoglobin abnormalities like sickle cell, thalassemias, and so forth. And because of this continuous lysis of red cells, the iron gets released and is stored in tissues. So they get hemosiderosis. And also, there are people, nowadays, it's not as common, but there are hemoglobin disorders like hemophilia, where earlier on, they used to get repeated blood transfusions. Also, people with hemolytic anemias also get these repeated blood transfusions. But these transfused red cells, when they get destroyed, the excess iron is stored as an exogenous load, so they get excessive iron in the form of hemosiderin. So this leads to what is referred to hemosiderosis, whereby excess hemosiderin is being stored in tissues. And we can see this, especially if we stain the tissues that are involved, the liver, the bone marrow, with a chemical referred to as Prussian blue. Prussian blue stains iron blue. So there are two ways of observing this iron. You either see it as a golden granular pigment in the cytoplasm, but remember, there are many other golden yellowish pigments like lipofuscin. So in order to distinguish it with hemosiderin, we stain with Prussian blue. And this hence leads, you see this is the liver, these granules look golden yellow like lipofuscin, but when you put in Prussian blue, then it stains this iron blue. And hence you know, oh, this is iron. So this person has excess iron in the form of hemosiderin, and we call this hemosiderosis. Normally, this excess iron does not cause parenchymal or impaired function. But when you find excessive hemosiderin, when it comes together in big clumps, this condition is referred to as hemochromatosis. It's an inherited disorder where there's excess iron absorption. And this has been seen especially in South African communities, whereby they store their produce in iron, and then when they are cooking with sulfurias, this iron, they absorb all that iron. This iron gets deposited in the liver, in the heart, in the pancreas, leading damage. So it leads to liver fibrosis, heart failure, and diabetes mellitus because of pancreatic damage. This excess iron is referred to, this condition is referred to as hemochromatosis. So it's hemosiderin and more iron which is being stored in tissues. But hemosiderosis by itself may not cause damage, but you may start noting them in tissues, and this is referred to as hemosiderosis. Here you can see iron, golden granular in the liver, but you can stain it with Prussian blue, and then you see this Prussian blue reaction where there is bluish everywhere. In the liver, in kidneys, in the heart, you can also visualize iron, especially in this condition referred to as hemochromatosis. I'll pause if you have any questions.
One student is asking, how is salt intake related to lipofuscin accumulation?
Is it associated with lipofuscin accumulation?
I'm not sure, but that's what the student was asking.
So there's no correlation per se, but we said lipofuscin is more of a tear and wear, seen in aged. So if the student's literally thinking kula chumvi is aging, maybe that is the association, but medically there's no association. We are just seeing it in old individuals or patients with malnutrition or cancer cachexia.
Okay, thank you. Another student is asking, is there a way to differentiate lipofuscin and hemosiderin representation?
Exactly, that's what I've said. Prussian blue. Prussian blue stains iron blue. So if you are want to differentiate it with lipofuscin, just put Prussian blue. If text blue, you know it's iron. If it's not, more likely lipofuscin.
Okay, thank you. That was the last question.
Okay, so let's swiftly move to another pigment that we had alluded earlier, bilirubin. Bilirubin is mainly found in bile. And you know, bile is secreted from our liver. How do you find bilirubin? We talked about hemoglobin. When you break down hemoglobin, there you have heme and globin. Globin is proteins, so it's broken down to amino acids that are used, that go back to the protein. Then we have iron. In heme, we have iron and bilirubin. Iron, as we have said, is transported in blood, in plasma, as transferrin, which then is stored in liver, bone marrow, as apotransferrin, which is a protein, forming ferritin and eventually hemosiderin if it's in excess. And this is what is recycled in formation of hemoglobin in bone marrow. What about bilirubin? Bilirubin is transported in plasma with the protein albumin. It's transported to the liver, where it's conjugated with another compound referred to as glucuronic acid. So bilirubin is conjugated with glucuronic acid, and then it becomes soluble. So this then is secreted together with the other bile salts and is responsible for the bile. You know about bile, you have slaughtered chicken and animals, and you see that bitter greenish pigment. So somebody tells you are bilious, you are very bitter. And it's because of that bile, which tastes awful. And this bile then is secreted into the gastric, into the intestinal contents, and part of it is also secreted in urine. It's responsible for the yellowish color that you see in the fecal material. In excess, you see it on the sclera of the eyeballs at that yellowish pigment we call jaundice. And hence, jaundice is excess of bilirubin pigment within cells and tissues. And in the lab, any amount above 1 milligram per deciliter will be manifest itself as jaundice, or 17 micromoles per liter. And here we can see bile plugs within the hepatocytes. And when you see these bile plugs, the cause now you can find out can either be, how do you classify the cause of jaundice? Have you been taught? Let me ask. Let me go to the participants. Chege Wamunyiri, are you there? Chege? Chege Wamunyiri? Okay, it's nil by mouth. Charlene Wanjiko? Charlene? Class rep, your students are not speaking.
Oh, sorry.
Are you also not responding? Class rep, where are your students? They're not speaking.
Oh, it's because I had forgotten to unmute them, sorry.
Hello.
Who is speaking?
It's Charlene.
Okay, Charlene, what are some of the causes of jaundice?
I can only remember one, which is, I think, obstructive.
Good. What is the cause? What are some of the causes of obstructive jaundice? What can cause obstruction?
Hello, can you hear me?
Yes, We can hear loud and clear.
I think it's anything that can become lodged in the bile duct, like stones, maybe.
Good. What else?
That's all I can remember.
We don't call them stones. We don't call them calculi. Stones is what you throw during a riot.
Oh, okay. Okay.
Calculi.
Okay.
Yeah. So calculi. Anything else?
I think that's all I can think of.
You have tried, but it's not enough. So if you look here, this here is what we call these ducts, Charlene.
The bile duct.
Which bile duct?
I'm sorry, I can't really remember. Sorry.
Have you done anatomy?
Yeah, we did.
The duct that comes, this is the gallbladder. The duct that comes from the gallbladder, what do we call it?
Cystic, I think.
Don't think, just say it's only one name.
Okay, cystic.
Yeah, cystic duct. There's also a duct that comes from the liver. What do we call it? So you need to go and revise. And then they join at one time and form one big duct called?
Hello, can you hear me now?
I can hear you loud and clear.
Okay, they'll join to form a common bile. The hepatobiliary duct, I think, is the one you're asking about before. They'll join to form the common bile duct.
So this is called hepatic duct, this is called cystic duct, and then they join to form the common bile duct. Okay, and there's a right hepatic, left hepatic duct joining the cystic duct, forming what is referred to as the common bile duct. So biliary calculi here can obstruct flow of bile, and that is one of the commonest cause of jaundice. And as you rightfully said, calculi. Okay, what else can obstruct? That's why it's called obstructive, because the only outlet is usually through this. What else can obstruct? Charlene, I'm still with you.
Maybe like a tumor. I don't know.
Exactly. Which tumors do you know? Do you know any tumor?
Tumors maybe metastasizing from like the liver or the gallbladder. Yeah.
Yeah, avoid saying I don't know, or I think. Doctors, we want you to know, want you to think. Okay?
Yeah.
So you say, let me try, or let me make an attempt, not I don't know. So there are tumors, and as you said, some tumors may metastasize to this area here, where especially the lymph nodes around the hilar region, hence blocking this. But commonly, there's an organ here around this region through which the common bile duct passes through. Which organ is that? Charlene? Which organ do we find around this region?
The pancreas. Yeah.
Yes. Yes, avoid, I think. It's called the pancreas. So the pancreas, tumors of the pancreas, especially the head of the pancreas, they will impinge or obstruct, and is one of the commonest cause of obstructive jaundice. You may also find worms that pass through the intestine and move into that, they cause that. You may also find strictures or fibrosis of that. You may also find tumors within the bile duct called cholangiocarcinomas. So all these may cause obstructive jaundice. So thanks, you have tried. Now that is called post-hepatic. Post-hepatic means bile has been produced and bilirubin is being obstructed from reaching the intestine. So we call that obstructive. So that is post-hepatic. There are hepatic causes, lesions or diseases within the liver that may cause jaundice. So let me see who is taking us through those. Chege Wamunyiri, I'm still on you. Chege, are you there?
Yes.
Okay, tell us. What are some of the lesions in the liver that may cause jaundice within the liver?
Hepatic jaundice might be caused by, say, cirrhosis, liver cirrhosis.
Okay, liver cirrhosis. Another?
Hepatic necrosis.
Necrosis. What is causing necrosis?
Say like you have a inflammatory response.
Okay, let's look at infectious conditions. Those are the common ones, infectious conditions.
Okay. Maybe hepatitis.
What do we call infection of the liver?
Hepatitis.
Yes. So all forms of hepatitis, hepatitis A, hepatitis B, hepatitis C, hepatitis E, hepatitis F, all of these hepatitis, especially when they are fulminant, they may lead to jaundice. And what is the cause of that jaundice? Is because of excessive accumulation of bilirubin in it. Okay, so jaundice. Another thing?
Maybe we might have also obstruction of the bile canalicule.
Well, not as common as what we have said in the obstructive jaundice. So in the liver causes, the other hepatitis. What are the other causes of hepatitis? Are there chemicals that cause hepatitis? Like the one you like taking?
Yes, alcohol.
Yeah, so you know yourself, you like taking alcohol. So in excess, alcoholic hepatitis and other heavy metals may lead to jaundice. So thank you. At least you have said a few things. Let me now come to somebody else. Dakshi Patel. Are you there? Dakshi Patel. Dakshi Patel. Dakshi Patel, are you there? So some of you are joining in and going to do your own things. I'm noting. Fatma Ahmed, are you there? Fatma Ahmed, class rep, where are these students?
I'm not sure, but I've given permission to unmute to the student you're asking.
Fatma Ahmed, class rep, not for me, these people are not responding. Gideon Dungu. Gideon Dungu. Hey, what's happening?
Yes.
Are you there? Gideon? Who has spoken?
Yes, he's unmuted.
Gideon Dungu, are you there? I can't hear him.
I think maybe he's having connection issues. Oh, no, okay, I can hear him now. Because sometimes I hear him, but sometimes I don't.
Gideon Dungu, are you there? Can't hear him.
Yes, I think it's connectivity because I can see he's unmuted.
You can unmute and not speak. There's also his namesake, Kamande Dungu. Maybe they're brothers. Kamande? Kamande? Kamande Ndungu? Interesting. Who knows other causes of jaundice? Because it seems like I'll stay here the whole time.
Hello,
Yes, who is that?
Bill Clinton.
Ah, good, Clinton. What? No wonder you are the president. Tell us about the pre-hepatic causes of jaundice.
So for pre-hepatic causes of jaundice, these are the causes of jaundice before it reaches the liver, maybe
Yes.
due to increased hemolytic of the red blood cells in the blood before it reaches the liver. So we have increased levels of bilirubin in the liver. Therefore,
So
conjugated levels
hemolytic
of,
anemias.
yeah.
So hemolytic. Do you know an example of a hemolytic anemia?
No, I don't know any.
Do you know any abnormal hemoglobin?
Yeah.
Like which one?
Abnormal as in the macrocytic, or there are others?
Okay, so the causes of hemolysis are myriad. So you can look at them as the hemoglobin itself. Okay.
Yeah.
Like sickle cell.
Oh,
So
yeah.
somebody with sickle cell hemoglobin, that abnormal hemoglobin gets hemolyzed. So it's an example of hemolytic anemias. So you're going to be taught about all these, the causes of hemolysis. Okay. So you can classify them as either immune or non-immune. You can classify them as either hemoglobinopathy or otherwise. These ones I leave to you, but that's correct, that there's excess red cell lysis, like in what we see in hemoglobinopathies. So this is what I was trying to put for you here. Another condition you can see here, there are children who are born with an atretic biliary duct, so biliary atresia, hepatitis, Gilbert syndrome, and so forth. These are the causes of jaundice. I'm going to stop there. I've taken more than 1 hour to take you through pigments. And to recap, today we were talking about pigments, which are colored substances. And we said they can be divided into two, endogenous and exogenous. The commonest exogenous pigment is carbon, and it's responsible for some of the lung problems that we see, especially in workplaces where there is excess production of these, like coal mines. It leads to a condition referred to as coal workers pneumoconiosis. Initially, the lung becomes fibrotic, not able to expand during inhalation and exhalation, and then it leads to this so-called emphysema, which is a chronic obstructive airway disease that progresses to pneumoconiosis and then failure. Then we looked at tattoos. Then we looked at a myriad of other pigments. We talked about melanin. We talked about conditions in which we have hypomelanosis, like albinism and vitiligo. We also looked at conditions where there is excessive melanin, like in tumors, or just generally suntan. But in tumors, we see these as nevi, or we can see them as malignancies referred to as melanoma. We also talked about lipofuscin, wear and tear. We talked about bilirubin, we talked about ochronosis, we talked about hemosiderin, and all these are some of the pigments. I will leave you to read others. There are others in the books, which needs for you to do as your homework. Okay, somebody that raised up their hands, you can ask.
Okay, I had a question concerning the post-hepatic causes of excess bilirubin in the human body or in the blood. Okay, from anatomy, you know that the CBD, or the common hepatic duct, is normally supplied by the cystic artery and the superior pancreaticoduodenal artery. They normally anastomose midway around the CBD. So I also thought that another cause of maybe this condition is when we have a defect in the anastomosis between the two arteries, it will lead to gangrene, or rather it will lead to the death of the common bile duct. So you'll find that the common bile duct kind of will undergo gangrene. And I think it will also be a potential cause of excess bilirubin in the blood.
Yeah, that's possible, especially post-surgery, sometimes they may get injured, and you find these places becoming necrosed, and then they become fibrosed. So you find what we call a stricture, which is a fibrosis of that bile duct stricture formation. So those strictures, which is a narrowing, can either be a benign stricture, like you have said, healing with fibrosis, or sometimes it can be a malignant stricture. We have an intraluminal lesion, cholangiocarcinomas, or sometimes around the pancreatic pancreas itself, so pancreatic head and neoplasms. So that's entirely correct.
Oh, I had a question.
Yes.
The second last slide,
Yes.
where the question about the child, and then there were options. So I was just asking, yeah, this one. Are all the options possible reasons, or which was the most likely?
So coming to you, if the young baby presents with jaundice and has dark urine and pale stools, what do you think? What's the cause of the jaundice?
Maybe hepatitis.
But in hepatitis, you still will have bilirubin going through, but it's only in excess. What does this pale stool mean?
I'm not entirely sure what the pale stool is. I just remember you saying
What
dark
does it
urine.
suggest? What does it suggest? Anyone in class who knows? If you hear pale stools, it means there's blockage of bilirubin reaching the intestinal contents, correct?
Oh, correct.
So it means that patient has obstructive jaundice. So in this, which one has obstructive jaundice? Physiological jaundice of the newborn is because of hepatocytes being immature. Okay? So that is referred to as hepatic cause. So most of these are hepatic causes. This is the one which is causing obstructive jaundice.
Okay, thank you.
Is everyone understanding? That's why I said you need to go and read about pre-hepatic causes, hepatic causes, post-hepatic causes. The post-hepatic causes are also called obstructive causes or obstructive causes of jaundice. And the key thing about obstructive causes of jaundice, definitely there will be jaundice. The urine will be dark because you remember that bilirubin also is secreted in urine, okay? So because of jaundice, also the urine will be deeply yellow. But the pale stools will tell you there is no movement of bile through the bile ducts into the intestinal contents. So when that is that way, then the stools are pale because there is no coloring by bilirubin. And the cause of that is obstructive jaundice. Some of these you learn as you go along. So I would like to end there. Thank you for your audience. Class rep, take for me the list of attendants. And I'll want you to be participating in answering questions. Is the only way I'll know if you understand or not. And the more you understand, the happier I am. Thank you for your participation. Unless there's any other question, I'll ask you to leave.
Thank you.
Okay, thank you, class rep. You may exit now.